Okay, so welcome to the AHA Heart Failure Asia webinar series. So in today's session, we will be talking about treatment inertia, understanding its impact to patients with heart failure and also exploring the possible solutions to reduce it. And this AHA Heart Failure Asia program is made possible with the funding support by Novartis. Here is the agenda of today. So I will first present you the award ceremony video. And we had 3 hospitals in the region achieve their bronze award in this program. So we wanted to celebrate their success with you all. Then I will introduce our speaker and also the Q&A tool to you. After that, I will invite Dr. Trump to present his insight on treatment inertia, and also Dr. Chang and Dr. Shi to share the approaches to reducing treatment inertia. So finally, we will have some time for Q&A session. Because of travel restrictions in different countries, we managed to have our award ceremony held virtually. So I'm going to proudly present you the 3 hospitals that received their bronze award and celebrate their success together.
The program inspired me with many creative ideas and helped me to take better care of our patients.
The American Heart Association recognitions for National Cardiovascular Center Harapan Kita is encouraging us to improve our effort in managing patients with heart failure. We are proud to get the guideline because our effort will be continued in a better way. Thank you very much.
This program helped to raise our facility healthcare worker awareness of the importance of GDMT and follow-up planning in heart failure patients at discharge. We can also see our pattern of managing heart failure and evaluate our performance in order to improve overall heart failure patient care. 3 months has passed and we already able to see the progress thanks to the determined multidisciplinary heart failure team. We look forward to the upcoming years of working together as a part of American Heart Association Heart Failure A.S.I.A program.
It's a great honor to participate in this meaningful international society-led quality improvement program. Through the concerted efforts of our team members and the systemic reminder mechanism in the hospital, our quality indicators have been improved from the unsatisfactory state in the past, and current medical quality have met the international standard. From this quality promotion activity, we also learned a lot. Thanks for the great support of the hospital administrative officers the consultation and guidance of the AHA consultants. Thank you, Amy and Luis. The full cooperation of various clinical units and the joint efforts of the team members. Thank you, my best partner, Yihua and Dian. Thank you very much.
So congratulations to the 3 hospitals who achieved their very first bronze award. So now I'm going to introduce you the speaker of today. So we have Dr. Jasper Trump, who is the assistant professor at the Sol Swee Hawk School of Public Health and also co-director of the Cardiovascular Clinical Trial Data Management Center at the National Heart Center, Singapore. So we have also invited Dr. Chung and Dr. Xiu, who you have just met them in the award ceremony video. So they are the clinical champions of the facility that are enrolled in our program. So it's our pleasure to have 3 of them share the experience on treatment inertia with us today. So just quickly remind everyone to go to the Q&A tool if possible, similar to what we have done in the previous webinar session. To join, simply open any browser in your computer or your mobile phone, type slido.com, slido.com, and then it will be prompt you to enter an event code, so which is HF Asia. Alternatively, I will post the Slido link to the Zoom chat box right now. So you can also click and submit your question anytime during the presentation. So with that, I will pass the stage to Dr. Trump.
Thank you very much, Amy. Hi, everybody. Let me just share my slides. So first of all, I also want to personally congratulate all the centers that won the award. It's undoubtedly a huge effort and I think a great achievement. And I'm very much looking forward to hearing from the fellow speakers later and how they reached that important milestone. But to begin today, I will share with you some of the data that we've seen on heart failure care in Southeast Asia and beyond, and how often treatment is used by patients who should be using it in the region. So these are my disclosures. So the first data I'd like to share with you is from Report HF. And Report HF was the first and largest global acute heart failure registry where, based on a single protocol, more than 18,000 patients were included in 44 countries that you see here on this map, across 358 sites from 7 world regions. So the unique thing about Report HF is that it had a substantial amount of patients from Asia, including Indonesia, Thailand, Malaysia, Vietnam, but also Taiwan, Japan, and South Korea. So it was an observational prospective registry where the only inclusion criteria was that the patients had a primary diagnosis of acute heart failure. So this was all determined by the treating physician at the time, which was part of the goals, was to see how, what type of heart failure patients do we see and what is their quality of care. So all of these patients signed informed consent, which of course had the effect that they were slightly less sick than the patients that you would normally see in their clinic, because the very sick patients were often not able to sign informed consent. And the only exclusion criteria was any concomitant participation in a clinical trial. So we showed the 1-year mortality, post-discharge mortality data back in 2020 in Lancet Global Health. And what you see in this map is the age and NYHA adjusted mortality at 1 year post-discharge, where countries that are more red have worse mortality than countries that are more lighter colored. And you can see that, especially here, countries in Southeast Asia, unfortunately, patients had very high 1-year post-discharge mortality. The highest what we found was in Indonesia, with a crude 1-year post-discharge mortality of 36%, 46% when we adjusted for age and NYHA class, but also countries like Thailand, Malaysia, India, unfortunately, very high 1-year post-discharge mortality. And this was specifically true for heart failure patients with a reduced ejection fraction. And you can understand that those patients are the one that we commonly treat. So the next question was, how does the treatment impact outcome, and how does that differ between regions? And I think, as many of you know, implementation of guideline-directed medical therapy for heart failure significantly improves outcomes. And this is a figure adapted from an earlier publication by Greg Fonarow, who very nicely showed that if you put patients on ACE inhibitors, beta blockers, and MRAs, you can reduce the 2-year mortality risk almost by 2/3. Now, this publication was from 2011. This figure was also relatively old, so you can imagine what would happen to the mortality risk if you add these newer drugs like SGLT2 inhibitors or ARNIs. So now the reduction is even more compared to no therapy at all. So we also studied this in Report HF to look at what are the differences in medication use between countries. And in this case, you're looking at a bar graph where we're looking at the use of medication in patients with heart failure with a reduced ejection fraction at discharge following their acute heart failure hospitalization, where countries were classified according to their World Bank GDP, so the country income level. And you can appreciate on the left side that MRA was provided only to less than half of patients eligible. So less than half of patients with heart failure with a reduced ejection fraction were on MRA at discharge. You see for beta blockers that this was only 52%, so slightly less than half. And you can all appreciate from this graph the very strong gradient that in countries like in Western Europe or in the US, we see a lot more use of beta blockers at discharge than what we see in countries with a lower income level, including in Southeast Asia. And the same was true for ACE inhibitors, though the gradient was a bit less strong. So what about the dosage, right? Because we know that there are guideline-directed dosages for patients. It's not just putting them on medication, it's also getting them to the right dosage. So what about the dosage among patients who are on medications? And that's what the map is showing here. So we calculated the dosages as the percentage of the recommended dose. And that's what you see here in the color. So the redder a country is, the lower the dosage that was used. And the more green a country is, the higher the dosage that was used. So you can also see from this map that unfortunately Asia was quite red. So that means that among patients who are on medication, so ACE inhibitor, beta blockers, or MRAs, on average, a lot of these patients were on relatively lower dosages. Now, we also know that there is a potential that Asian patients, for example, might be more sensitive. So because they have smaller body sizes, people are maybe less able to deal with high dosages of medication. But at the same time, we do see a similar gradient for mortality. I'm going to come back to that later on. So this is another map showing patients who are on a combination of drugs. So in this case, ACE, ARB, ARNIs, and beta blockers as a percentage. And you can again see that, unfortunately, our patients in Asia, and I'm based in Singapore, so we have that same issue, are not always on the medications where they should be, because they, in this case, were very light colored, which means that a very low percentage of these patients were on a combination of both drugs. So what are some of the most important predictors of not being on medication? And that's what this slide shows. So we did multivariable analysis. We corrected for confounders. We corrected for center type and clustered within the country. And we saw that independently of confounders, particularly women, those without health insurance, and patients from Southeast Asia were least likely to be on all 3 medications. And this was at 6 months post-discharge. Now, if we repeat this analysis at discharge, we would see the exact same image, because what we also saw is that patients who are not at medication at discharge were likely not going to be on medication at 6 months post-discharge or at 1 year. So that means that also that post-discharge period seems to be a unique window of opportunity to get these patients on the medication that they should be getting. Therefore, it's also not surprising that those patients who did not have a follow-up visit, so those who did not see a healthcare provider between discharge and, in this case, a scheduled 6-month follow-up point, were less likely to be on medication. And that goes for those who saw a GP or a cardiologist or internal medicine doctor. All of them were more likely to be on medication compared to those who did not. So not to zoom in on some of the countries, just to show you some of these differences. Now, you have to understand, though, that within Report HF, not every country is sort of, some countries had only a few centers included. That means that these countries might not be representative for the whole of the country. So in this case, we're looking at Vietnam. This might be true for those centers included in Report HF, but it might not be true for some of the centers that you're practicing at. But we did see in Report HF that patients from Vietnam were considerably younger compared to what we see in Western Europe, for example. So they were only 65 years of age on average, with a 27% mortality rate at 1 year, which is relatively high compared to 19% in Western Europe. And among those eligible, about half were on beta blockers, though they did pretty well on ACE inhibitors and MRAs. So this is Indonesia, I already mentioned. So the mortality rate here was highest, accrued mortality rate at 1 year of 36%, despite the fact that these patients were among the youngest. So they only had a mean age of 55 years. So very young patients, very high mortality. Slightly above 50% were on MRAs or beta blockers of patients with HFrEF at discharge, but almost 80% for ACE inhibitors. So you see the room of improvement here. And then finally, Thailand, similar, 65, so a bit more close to Vietnam. Again, 27% mortality rate, only 27% on MRAs. So very low use of MRAs compared to other countries. What about the association of dosages with outcome? Does it matter? So that's also what we tested here. And what we've seen here is more confirmatory, because obviously in these big trials, they've shown in a randomized way that being on a drug like ACE inhibitors, beta blocks, or MRA is beneficial compared to not being on the drug. But they often did not look at dosages. And multiple registry studies in the US, in Europe, but also in Asia, and this is part of that, have shown that being on higher dosages confers a survival benefit. So here on the y-axis, you see the survival probability, and on the x-axis, the time in days. And the red group are patients who are on less than 1% of the recommended dosage. So they either are not on the drug or a very low dose. And you can see, compared to those who are on 100% or more in green of the recommended dosage for ACE inhibitors or ARBs, they do significantly worse. And a similar gradient can be found for beta blockers, though it was a bit less clear for MRAs. And these data were all corrected for any treatment indication bias and confounders. So this was independent of that. So could this be simply because we're looking at one data set and particular hospitals? And that's why I think it's important to also show you a bit of other data that we've produced somewhat earlier from Asian HF, which was the largest registry to date performed exclusively in Asia, with 6,400 patients with heart failure who are prospectively included from Northeast Asia, South Asia, and Southeast Asia here in blue. And you can see the countries in the boxes over here. So we had patients from 44 centers, 11 regions, and outcomes up to 3 years, and about 5,500 patients with a reduced ejection fraction. So other than Report HF, these patients were predominantly outpatients, so they were relatively stable. They were not acutely decompensated. So you would expect that more of these patients were on guideline-directed medication. And that's what you see here. So this graph shows a bar graph for the regions included in our registry. the percentage on the y-axis, the countries on the x-axis. And here, this percentage expresses the percentage of patients on both ACE inhibitors and beta blockers. And you can see that compared to countries like Singapore, Hong Kong, or Korea, fewer patients from Thailand, Malaysia, Indonesia, or the Philippines and Taiwan were on a combination of these two drugs. And this was not necessarily a discharge. Remember, these are outpatients, so they're relatively stable. So again, similar to Report-HF, we do see the room for improvement here. Then again, when we look at dosages, here again, we see that the median percent of guideline recommended dose was only 33% for ACE inhibitors. That means that almost half of our patients who are on the drug were on less than a third of the recommended dose in the Asian HF registry. And you can see that countries like India or Indonesia did relatively better. So among those who were on drugs, and in this case, a more red color means that they were on a higher dose. So these countries or patients from these countries were on a relatively higher dose, and patients from, for example, China or Japan did worse. The same was true for beta blockers. The median dose was only 25%. That means that half of our patients were on less than 25, the recommended dose for beta blockers. And again, Indonesia actually did relatively good. Philippines, Thailand also did relatively well. We see very low dosages in India, for example, or in Japan. So just to also touch again upon that gradient. So what you see here is a forest plot showing the association of these categories of recommended dosage. So 1 to 25% for ACE inhibitors, 25 to 50, 50 to 100, or 100 and over. And this is an association with an outcome of all-cause mortality or heart failure hospitalizations at 1 year. And you can see that compared to patients who were not on the drug, so they were at 0%, the risk of dying or getting hospitalized within the first year after inclusion in the registry was lower for patients on higher dosages, right? So again, you see that same gradient, that patients who are closer to the recommended dose generally do better. The same was again true for beta blockers, like Report-HF, a very strong gradient. So it seems that for beta blockers, especially dose matters. And in MRA, again, it's a bit less clear, similar to Report-HF, and there might be some residual treatment indication bias there that we couldn't correct for. So in conclusion, I think we've seen that patients in heart failure, with heart failure in Asia, and especially in Southeast Asia, have a considerably higher mortality rate than what we, for example, see in Western Europe or in North America. And unfortunately, a lot of these patients who should be getting medication that would reduce their mortality risk are not on these medications. And particularly in the Report-HF registry, these were women, patients without health insurance, especially patients from Southeast Asia. We consistently see, including in our Asian registry, that being on a higher dose of medication is associated with improved outcomes, especially for ACE inhibitors and beta blockers. So I think these data highlight that there's an important need to improve the quality and access to care for our patients with heart failure. And with that, I'd like to thank you for your attention.
Thank you, Dr. Trump. So I would like to invite our next speaker, Dr. Chang.
Hello.
Yes, hello. Can you share your screen, or you want me to share from my side? Okay, thank you. So I will pass the stage to you. Thank you, Dr. Chang.
Hello, good evening, ladies and gentlemen. I'm Dr. Hongyu Zhang from Zhenxin General Hospital, Taipei, Taiwan. Today, I would like to share the solutions in my facility to reduce treatment inertia. Among American patients hospitalized for HFrEF and eligible for therapy, deferring initiation of GDMP to the outpatient setting carries a high chance of not initiating them within the next year. Looking into the challenges that I faced about treatment inertia in my own hospital, because there's no so-called heart failure specialist in my healthcare system, every attending physician may take care of heart failure patients by themselves. The weak points in my facility include first, of course, busy clinical loading. Second, young staff are not familiar with GDMT and therefore they will not prescribe them. Third, in our healthcare system, insurance pay for A.S.I.A, beta blocker, and MRA, but there are selective payment regulations for ARNI and SGLT2 inhibitor, which limited the use of these novel medications. Finally, because health insurance pay for heart failure hospitalization and there's no punishment for repeated hospitalization, some people might think that it is not a big deal to have readmission, and they might think that it is not important to optimize pre-discharge medication. And I wonder that can we use computer to remind us? First of all, if we want to use computer, we have to define GDMT clearly. To avoid misunderstanding, we use anatomical therapeutic chemical classification code to identify GDMP. For example, C09CA03 refers to valsartan, and C09DX04 refer to valsartan and sacubitril. During hospitalization, if computer does not identify specific medication by the ATC code, it will alert physician when he or she enters orders. At discharge, if computer does not identify specific medication by the ATC code, it will remind physician and he or she must choose the reason for non-prescription. The next question is when to remind. According to our National Heart Failure Registry, median length of stay for heart failure is 8 days. Therefore, we decide to set the computer reminding system on day 5, day 8, and day 11. This is an example. At day 5, when I choose this patient, 1101, the diagnosis of this patient does not include heart failure, so computer will not remind anything. When I choose this patient, 1105, you can see this patient has HF labeling because he has dilated cardiomyopathy and admitted due to acute decompensation. In the next step, when I want to enter orders, computer will automatically detect whether GDMP or prescribed or not. For example, this patient did not receive beta blocker at day 5, so a remind will pop up. I can still choose remind me later or don't remind me. If I choose remind me later, the same remind will show again next time when I want to enter orders. If I choose don't remind, but I still do not prescribe beta blocker, computer will remind me later in date 8. At discharge, if GDMT were not prescribed, reason for not prescribing should be stated. This is the translation in English. As you can see, we list a lot of reasons for non-prescribing beta blockers, including hypotension, bradycardia, peripheral artery disease, and asthma. This is the historical data of GDMT prescription at discharge in my country. As you can see, the prescription rate is not much improved from 2012 to 2019. But since 2020, we introduced computer learning system. At day 5, computer detects the prescription rate of A.S.I.A ARNI 62%, beta blocker 67%, and MRA 51%. After reminding, the prescription rate of all 3 classes of GDMTs increased largely. As you can see, the absolute prescription rate of A.S.I.A ARNI, beta blocker, and MRA increased by 12 to 15% from day 5 to discharge. Comparing with the REVEAL heart failure study reported by Yale School of Medicine, we have similar prescription rate of A.S.I.A ARNI, lower prescription rate of beta blocker, but higher prescription rate of MRA. Another advantage of this computer system is to identify cardiologists who had treatment inertia. As I mentioned before, a total of 22 cardiologists who may take care of heart failure hospitalized patients in my facility. The prescription rate of some physicians were quite low, so we can reach out to these physicians to understand what hindered them to use these drugs. This is my last slide. Although we have set up an alarming system, there is still a long way to go. Do clinicians really pay attention to alert? Alert fatigue may happen, and when you only have limited time for entering orders, alert means nothing at that moment. The next step is how to increase awareness. We may have alarming system online, but should also have clinical pathway, checklist, or standard operation procedure for backup. Moreover, we should alarm the key person who can take responsibility for patient's treatment strategy. Thanks for your attention, and I'm happy to answer your questions.
Thank you, Dr. Chang. So we will save the question to the end. So I just sent the link for the Q&A session to the Zoom chat box. So please submit your question to the Q&A tool that we will go through at the end of the webinar session. So next, can we invite Dr. Shiu to share?
Okay, sure.
Thank
Hello,
you.
everyone. Good evening. So firstly, I have to stop other people's sharing.
Yeah. Yes.
Okay, from here. Share. Can you see my slide?
Yes. Thank you.
Yeah. Good evening. It's my pleasure to be here. I'm Dr. Chen Yishu from Taipei Medical University Hospital. Today, we'd like to share our little experience regarding the treatment inertia and how did we improve our data, these measurements during the A.S.I.A quality improvement program. Firstly, we'd like to introduce our hospital. We are from Taipei Medical University Hospital. Just like its name, we are from Taipei, and its location is in Taipei, Taiwan. So our hospital is located in the Xinyin district, which is near the Taipei 101 building. And we are the university hospital, is belong to the Taipei Medical University. It's a private university for medical education. So we were one of the associated hospitals in here, and we have the teaching hospital responsibilities. And nowadays we have totally 727 registered bed and 29 registered medical departments. And the full-time employees were more than 2,000. And just like what Dr. Trump and Dr. Zhang mentioned about, there are quite embarrassing data regarding Taiwan's presentations. Just like the past registration from our societies, it's called TSOC HFrEF registry. And in this review article, which was published last year, the topic is just like the similar to our today's topic, is making the discussion about the clinical inertia in the treatment of heart failure. So the authors have listed a lot of studies, registries, and surveys regarding the drug adherence in here. Just like what Dr. Trump just mentioned, that we have a pretty low performance regarding the prescription for GDMT for patients with HFrEF. So just like what we saw, the percentage for ACE and ARB was only 60%, and beta blockers were only 60%. And MRA was even below 50% of patients who received the medicine. If you look at the dosage, the target dose was even lower. So patients who received the target dose for ACE and ARB were only 5% in our previous registry. So we are going to working on another registry in modern era to look at what have been changed in these 8 to 10 years. And if you look at the key performance regarding this AHA program for the quality improvement, totally we have 8 indicators, 8 measures, 4 were the requirements for the optional measures. So all of them were mentioned about the drug prescription rate regarding ACE&R, beta blockers, and MRA, and as evidence-based SGLT2 inhibitors. So we actually have a lot of space to improve from the previous performance to the current measurements. What the targets we have to achieve is above 85%. So there's a lot of way to go. Here's the capacity of heart failure patient in our hospital in the recent 3 years. So from our statistically belong to the official data from our hospital, we have annually around 30,000 of patients who were admitted to our hospital. And this trend was declining just because of the COVID-19 pandemic. So the patient amount is declined. But if you look at the diagnosis of heart failure, they were almost steady in the past 3 years, almost around 1,000 of patients who have the diagnosis of heart failure. I think this number must be underestimated because the diagnosis for it may need some standard coding. So one of the reasons is that physicians treating patients with symptoms of heart failure, but they didn't have the ICD code on the discharge diagnosis. So maybe we have to further dig out these patients and give them the right treatment for them. And here's the percentage for the main diagnosis of heart failure. They were around 30% of them have the main diagnosis, and for patients who were admitted to our hospital. And among them, you can see that there's a trend for declining of this HFrEF percentage. In 2020, we have 55% of patients who have the ejection fraction less than 40%. But nowadays, we have the majority of patients who have the ejection fraction above 40%. So I think maybe in the modern era, we have more awareness for patients, even they don't have the traditionally impaired ejection fraction. This patient were identified by the biomarker and the awareness of physicians. And now we also have entered the program, which was called Heart Failure Post-Acute Care Program. It's held by the government to try to improve the quality of care in our country. So if you look at the patients who were eligible for this program, patients with HFrEF, almost half of them were entered the PAC program in our hospital. So how to implement this program to improve our qualities by this heart failure guideline, get with the guideline program. Firstly, we have to look for our partners. So here's the working groups. We have cardiologists, but only the physicians' work cannot beat the treatment inertia. So we also include our case coordinator, that's our case manager, who can coordinate all the multidisciplinary care during the hospitalization patient to improve their qualities. And then we also have the clinical pharmacists. They did a lot of efforts to this program promotion. And we also have joined the administrative units. This is the Department of Quality Improvement Management. So they joined our team and build up, we get more resource to improve these qualities. It's just like the numbers that I mentioned in the past slide. You can see that in our hospital, almost half of them were the HFrEF patients, and even another half of them were entered the heart failure PAC program. So let's just calculate the number. You can see that only 26% of patients who were admitted to heart failure were enrolled in this program. So we have to identify those who did not meet the enrollment criteria for this PAC program. So we did need the notification system for heart failure patients who were admitted to our hospital and even to other specialties service. So this is the issues that we're facing. The first thing is that the GDMT prescription rate is still suboptimal, and the SGLT2 inhibitors and the lipid-lowering agents were even lower, which is not included in our protocols. So I think the next thing we have to make more efforts is to do the automatically inform system, just like what Dr. Zhang said. We need alarm system to remind us what kind of patient we should treat them with dialect-directed medical therapies. So I asked our IT system, IT department to inform our case manager when a patient is admitted with ICD diagnosis for heart failure. We should be informed. And even patients was the emergency department, they didn't have the code for heart failure. If they were have the acute dyspnea symptom and they were using Lux diuretics to treat their volume overload, we will also be noticed from the very beginning when the patient is going to admit it from the emergency room. And then after notifications, our case care coordinator will contact with the, we will first have to check whether the diagnosis is correct or not. And we will need some expert checkup. And so the effort was done by the case manager and our young fellows. And then we have to contact with the primary care team, and they will check their performance for these 8 items before the patient's discharge. And here's our case management system. So the system will alarm us when the patient have the potentially become a heart failure diagnosis. So here's some items which can, the data can be imported. The first thing is the ICD code. The B means NT-proBNP, these biomarkers. E means echo. The echo data will be imported in here. The ejection fraction numbers in here. And the D means diuretics. Patients who were admitted via the emergency room may have received the diuretics to improve, to optimize their volume status. And after checking for the ejection fraction, the NT-proBNP data, and also incorporate with the kidney function, we will have a recommendation for medication list in here. So for patients with HFrEF, we'll remind the primary care physicians whether they should receive ASARB or ARNI or beta blockers. And in this patient, she had an estimated GFR less than 30. So I think the SGLT2 inhibitor was not indicated in that situation. And the MRA was relatively dangerous because the kidney function is not that well. So we have a remind for the physicians, maybe this kind of medicine should be avoided at the very beginning. And here's the patient system. So the case management, the care coordinator will fill in this blank to see whether the patient have what kind of AHA stage, the NYHA functional class, what's their heart failure types, what's their potential comorbidities and their etiologies for heart failure. And ideally, I think we would like to make the computer system more convenient. In the next step, we hope we can further classify the different manifestations for heart failure for their from the IT system. For example, maybe we can classify these patients from just like the ESC heart failure consensus. We can divide them by different heart rate, different blood pressure, different eGFR, kidney function, and the AF status. And after giving these information, we can give the primary care team appropriate treatment recommendations and give our patient good help for their GDMT they should receive. And here's the heart failure team working process. After the patient admitted, our case manager will cooperate all the multidisciplinary teams, including the pharmacist, the physical rehabilitant, and the dietitian. We also code for telemedicine before the patient discharge. So after these efforts, we will give the patients a lot of educational information, just like the QR code in here. We will give them videos for the heart failure education, including the pharmacological informations. And here's the heart failure medication reminders. Because we have limited brand for ACE, ARB, and beta blockers in our hospital, so we just make an individualized heart failure program, just like the educational book for each patient. So after giving them the checklist, they will also remind, the pharmacist will also remind the clinicians to pay attention to the GDMT, whether they received or not. And after discharge, when they come back to the outpatient clinic, we will also have the pharmacy education program. The clinical pharmacist will gather the information of the patients, and it will also give us some professional recommendations, just like we have to uptitrate beta blockers to their target dose if the patient can tolerate it with it. We have to check for the levels for digoxin and monitor their kidney functions. And this kind of reminders is very useful and it's very important for us. And after these efforts, you can see that the medication-related key performance indicators were much improved. So from the very beginning, here's the baseline when we enter the AHA with the guideline program. And after initial implementation from the first 3 months, you can see a significant improvement here. And after the implementation for half a year, you can see that the numbers will almost achieve the goals. But we still have some things, some space to improve, including the prescription rate for SGLT2 inhibitors and lipid-lowering drugs. I think a big reason for this, 2 drugs were not optimized just because some physicians, I think not some, the majority of the physicians didn't think this kind of treatment needs the dilated medical therapy for heart failure patients. So we have to remind them in the future. And here's all the KPIs month by month presentation. You can see that indicators were all improved in a trend of pretty nice improvement. And here's the comparisons between the last half year in 2021 and first half year in 2022. The improvement of all indicators were quite promising, but it's just like what I mentioned, lipid-lowering drugs and SGLT2 inhibitor prescription rate should be improved in the future. That's why we get maybe a Bronze Award, but we didn't get the Bronze Plus Award. That's one of the reasons we still need to improve from that. And here, the last thing I would like to mention is about the event code that AHA get with the guideline program. But actually, the latest ACC-AHA guidelines were published in April this year. We have the new guidelines and a lot of new information inside. Just like the tables shown here, the GDMT's recommendations were changed a lot across heart failure stages, and these informations were never been clearly recommended in the past guidelines. So I think because of more and more information that we have to pay attention to, so I think the IT system should be established and be designed to help our physicians to facilitate further treatment, to improve the guideline implementation to the current treatment strategies and improved outcomes of our patients. And here's the little experience I would like to share. And thanks for your attention. Thank you.
Thank you very much, Dr. Shui. So I will take the presenter's ball and share the questions that we have gathered through Slido. So for those who want to submit their question, I am not going to send out the link once again so that you can submit your question. Okay, so first of all, I think this question is for Dr. Jesper Trump. So some patients were found not on the 3 medication at 6 months after discharge. So what did you, in your study, were you able to find the possible reason for them not prescribing the GDMT at discharge?
So the reasons were not captured in that particular study, but we do know that it was consistent among patients with versus without CKD, with versus without COPD, and although contraindications that might cause reduced use of these drugs. I think the other part is that we see that patients from Southeast Asia, for example, were least likely to be under drug, but these patients were actually objectively youngest with fewest comorbidities and then also had fewer relative contraindications. So and to speak to that, at least from data from the US, I think one of the only studies that did capture, to a degree at least, reasons for not being on drug was CHAMP. And I think what we've seen in CHAMP-HF is that a significant proportion of that not being on the drug is actually, inertia. And I think our two colleagues of Taiwan really beautifully spoke to that and how they dealt with that. So, but it will depend on the individual country what the reason is. Because there might be other barriers like insurance in Taiwan, out-of-pocket pay in India or Philippines, other parts of the health system that will, so how big of a chunk that sort of treatment inertia is will be very different on a country by country basis.
Okay, thank you. So the next question is for Dr. Chang. So when you reached out to those doctors demonstrating treatment inertia, so how open were those doctors to make changes in their practices?
Well, it is a very good question. First of all, when I designed this computer learning system, I am not to influence physicians' decision. So in the very beginning, I just make a remind, and it's up to them to adjust their medication. And later on, I will try to reach out to them and discuss with them about their treatment strategy. Of course, if the patient, if the physician did not prescribe medication due to less of confidence because they feel they are afraid of the side effect, adverse effect of this medication, we can discuss about this, and they might feel happy to make some changes. But for some physician, well, it's quite difficult because I must say that some did not believe in guidelines, so it is very difficult to make everyone follow the guideline treatment. Okay, thank you for your question.
So for I just curious, for those who are not believing in guidelines, so how did you approach to those doctors?
I will try to say that, hey, we are join a quality improvement program. It is the whole, we need to join together. So would you like to make some changes?
Okay, so making it as everyone's responsibility as a team goal. Okay.
Yes.
Yeah, thank you very much. So the next question is also for Dr. Chang. I would like to know whether clinician in ambulatory clinics, I think ambulatory or outpatient clinic, will also get some reminders through the alarming system regarding the GDMT prescription as well.
Okay. Unfortunately, the system of outpatient clinic is different from the system of the hospitalization. But for the patients who have so-called HF label, heart failure labeling, this can be found in the outpatient system. So clinicians can identify this patient by themselves, and if they wish, they could prescribe guideline-directed medical therapy. Okay, thank you.
Thank you. So we have done this, and we have the very last question. So I think the audience are really impressed by the solution that you guys have demonstrated. So they would like to see what kind of challenge that you face when you implement the different solutions. So the alarming system, implementing our working group, using the patient education material to remind physician to prescribe the guideline-directed medical therapy. So what were the challenge that you faced when you implement these solutions, and how did you resolve those challenges? So maybe Dr. Shiu, go first, and then we invite back Dr. Chang.
Okay, thanks. I think the most challenge is from people. So just like the first question to Dr. Chang, I think how open is the quality improvement things put into individuals how open they will accept it or not. It depends on their mind. So for some senior physicians, maybe it's more difficult to communicate with them. So I think the most important thing is that through this program, we have a very official reason, official purpose to make them get with the guidelines with us. So I think it's a very good, a very good program for a single hospital to improve their qualities. And after that, we can also use the force from the administrative units. From the hospital efforts, that will be more easily from the up to down to the basic primary physicians, instead of the personal improvement from their knowledge and their practice ways. So I think that's the most important thing, that we have the authority to order them to follow us. Okay.
Thank you. So anything to add, Dr. Chang?
Oh, yes, it's really, there are many challenges. For example, when I designed this system, and people, they know how to ignore the alarm. So if I repeatedly pop out the alarm window, it is really annoying, but they still ignore the alarm. So now we try to resolve this. In the future, we might send alarm to the cell phone rather than using the computer system, because when you are busy entering order, you tend to ignore everything. You just want to enter the order you want to enter. So if you have another system to remind you, and that might help. I don't know. Then in the future we will try to do this. This is my personal experience. Thank you.
Thank you. So we still have 2 minutes. Any last minute question from the floor? Okay. Maybe Luis, you have something to share before we close the meeting?
Sorry, I had to get off mute, and now I'm trying to come off camera. Okay, sorry. No, I really appreciate that, Dr. Trump, for helping us to all realize realize that treatment inertia exists. We know it exists, we just don't think about it often. So I think it's a really important concept for all of us to think about, particularly in the setting of heart failure, where we know that the therapies are often initiated at lower doses. And then we also need to, continue to evaluate the patients and try to, titrate them up to therapeutic dosing. But the very first step is absolutely to ensure that the patients receive appropriate prescriptions for guideline-directed medical therapy. So these efforts for your patients in the hospital setting are really critical to the kind of the long-term management of the patient. So, I really appreciate, this topic being presented to this group to help us to just develop that awareness, and then to our physicians, leaders at the hospitals that have worked really hard to try to figure out how do we make that happen in a very consistent and regular way. So I hope that others that are joined this call, whose hospitals are working hard to, really improve the consistency of delivery of guideline-directed medical therapies, may find some little strategies and tactics to employ at your hospitals to help you to, achieve this success as well. Because remember, yes, it's about our performance as providers, but it really ultimately is about the outcomes for the patients. So it's good for us to keep all of that in mind when we're thinking about what our participation in this program can help accomplish at your institutions. Thank you for the opportunity to offer those comments, Amy.
Thank you, Louise. Thank you, Dr. Trump, Dr. Chang, and Dr. Shay for your sharing. So thank you everyone also for your time to being in this webinar session, and we will see you all next time. So thank you. Bye-bye.
Thanks all.
Thank you. Bye bye.
Bye.
Thanks.
Bye.
Bye-bye.